Immunotherapy in HCC. Welcome to you all. Now I request Professor Mamun Mahtab, Shwapnil, Chairman, Hepatology Department, Bangabandhu Sheikh Mujib Medical University, to moderate to this session. Thank you, sir.
Thank you, Dr. Rahim. It is our great pleasure today, ladies and gentlemen, that we have with us Professor Seng Gee. He is an authority in hepatology with special interest in hepatocellular carcinoma. He is currently the head of the Department of Hepatology at National University Hospital, Singapore. It is a pleasure for us to, an honor for us to have him here tonight, this evening. He will be talking on the latest approved therapy for HCC, immune therapy. We have a very eminent panel of experts today. With us, we have Professor Dr. Salimur Rahman, former UGC Professor of Bangladesh. We have Major General Azizul Islam. He is the Consultant Physician General of Bangladesh Army Medical Corps and a very senior oncologist of the country. We have Dr. Sheikh Muhammad Fazla Akbar, a very senior hepatologist of Bangladeshi origin, joining us from Japan, where he works for the last 30 years. And finally, we have Professor Dr. Kamruzaman Chaudhry. He's also a very senior and eminent oncologist of the country. So without further delay, I request Professor Seng Gee to please enlighten us with his lecture. Professor Lim, please. Seng Gee, please.
Well, thank you very much, Mamun, and I'd like to thank BSMMU for hosting this very important seminar. And really, there's been a lot of exciting news in the field of HCC. For many years, all of us were really disappointed, I would say, about the treatment options that were available. But before I actually go and discuss these treatment options that were available, let me, first of all, tell you a little bit about the series of webinars that we're planning to come up. If you go to the Singapore Hepatology Conference website, you will see that actually we've had quite a lot of past webinars, but I just want to tell you about the upcoming ones, starting from next week. The scope of advanced liver disease, hepatocyte transplantation, portal hypertension update, advances in hepatic encephalopathy, long-term albumin replacement, a panacea for decompensated cirrhosis, and best management practices for diuretic-resistant ascites and hepatorenal syndrome. Now, I would also like to inform you that these speakers are some of the leading experts in the world in this field. So it's going to be a real pleasure to hear from these experts on how to manage advanced liver disease, which I think is a common problem throughout Asia. Of course, tonight we have the pleasure of BSMMU hosting, together with Singapore Hepatology Conference, the discussion on immune therapy for hepatocellular carcinoma. Let me also remind you that this is actually a sort of a summary of a series which was supported by Roche. As you know, Roche has a very important role in immunotherapy for HCC, and they were funded one of the major articles that was published in New England Journal of Medicine, which I'm going to discuss a little bit later. And all of this, if you want to look at the 6 videos and the 3 webinars that were hosted, you can please go to the Singapore Hepatology Conference website, because the slides as well as the videos are available and the webinars are available. And you can see that we had very prominent speakers, Dr. Han Chong To, Thomas Yao, Robert Gish, Dr. Chi Chen Yin, Dr. Professor Pierce Chow, and Kamarjit Singh, all who spoke on the changing practices on advanced and intermediate HCC, where we actually are able to enhance survival with cancer immunotherapy. So my webinar tonight is really going to be a summary of this webinar series, which ran over something like 2 months. And as I said here, these are some of the videos that you can access, as well as the slides that are available for you to access as well. So you'll have to forgive me because, you know, it's a lot to summarize in half an hour, so I'll try and do my best. But really, the details of all this discussion can be addressed can be viewed at the website. And moreover, I would say that you should go and attend the webinars, which are no longer live. Of course, they're recorded, but there were case discussions, and those cases are very, very illustrative of the management strategies that we can undertake today with the immunotherapies that are available. So I want to start off by just reminding you that liver cancer is the fourth most common cancer globally, and liver disease is almost universally present. However, most patients present in the intermediate or advanced state of disease. So consequently, there's not much you can do for curative therapies in this group. In fact, it's said that curative therapies are only available in about 20 to 30% of patients who present with hepatocellular carcinoma. And you can see that based on the BCLC staging, which now is a universal stage for liver disease, we can see that survival rates are actually only possible if you present early. If you present with advanced stages of liver disease, such as BCLD or C, then the long-term outcome and survival is extremely poor. Now, one of the things that we need to understand about cancer therapy is that cancer starts off with a very small cluster of cells which are malignant. And in the preclinical stage, you can see here that the patients are completely asymptomatic. And there are 30 doublings during this period of time to get 1 gram of tissue. But there are only 10 doublings between that and the development of clinical disease. And by the time you get to 1 kilogram mass of tumor, then there really is no possibility of a cure, very low possibility of a cure. So this sort of schema of anti-neoplastic therapy is to try and reduce the tumor mass. And obviously this can be done only when the tumors at a relatively small stage. And you can see here, it should be definitely less than 1 kilo, because a 1 gram mass contains 10 to the power of 9 cells, and is probably the smallest tumor burden that can be physically detectable. So you can imagine that a gram of tumor contains 1 billion tumor cells, and clinical symptoms generally occur at this stage. And you think about how small 1 gram is. So if that's the case, then really you'll have to look at mechanisms to try and reduce tumor burden. Now, the first thing is that surgery is possible, and that will reduce tumor burden, and then you can implement curative chemotherapy. The curative chemotherapy on its own, I think, is only possible if the drug combinations are able to reduce the tumor burden significantly. Otherwise, there's a progressive increase in tumor burden, and really at this stage where there's more than 1 kilogram of tumor, then you only can manage with palliative chemotherapy. Now, is this going to change with immune therapy? That's a very good question. We don't know, but certainly that may be possible. And just to remind you that hepatocellular carcinoma progresses through different stages of disease, and that the very early stages you can only detect on screening, because it's seldom discovered when patients are symptomatic. And by the time patients are symptomatic, you can see that they're usually in the intermediate stage of disease. I don't need to remind you that the basis for staging is really the BCLC staging system. I've already shown you prognosis there before. And basically, there's stage 0, there's stage A to C, and there's stage D. And for the stage 0 cases, resection, local regional therapy is the standard of care. For the early stage 2, you can use local regional therapy or liver transplant very successfully. But once it reaches intermediate stage and advanced stage C, then really the options are less optimal for local regional therapy. And you can try and achieve therapies that will get you to an overall survival of 20 months in the case of intermediate child stage B, and for C, 11 months. Now, that may all change, because if you have stage D, you're really terminal and you have only best supportive care. So the treatment options really are quite dim has been quite dim for hepatocellular carcinoma through the last few years. Now, before I discuss the therapies that have been tested and available, I think we need to understand how we measure the outcomes of therapy. So this is something that oncologists are very familiar with, but I think GI and hepatology people are not as familiar with the outcomes. And I think all oncologists, and particularly those working in HCC, understand that the primary endpoint is overall survival, or also called OS. But overall survival can take quite a long time to achieve, and is not always easily measured if your therapy can go on for a long time. So we want to know whether we have surrogate endpoints that are able to give us an indication that therapies are working, because in overall survival, you may need larger. It's really the outcome for phase 3 studies. But for smaller phase 1 and phase 2 studies, you may be able to use surrogate endpoints. And these are the ones that have been used commonly. PFS, or progression-free survival, where death and evidence of radiological progression defined by standard criteria such as RECIST or mRECIST. Time to progression is the time between the trial allocation and the radiological progression, defined by standard criteria again, such as mRECIST. And objective response rate, or ORR, where the RECIST standardized methods for converting radiological observations into a quantitative and statistically trackable framework. So a 30% increase, for instance, the diameter of a target lesion is such an example. So ORR is a percentage of patients who achieve an objective tumor response measured by mRECIST. And you can see here, in the top graph here, is overall survival. And you're familiar with Kaplan-Meier graphs, and you can see that these are survival graphs. But the time to progression actually, or TTP, actually is measured in a different way. You can see here in orange, the time to progression is the median time, in this case, of patients who had a PD, or progressive disease. Progressive disease, 50% those who had progressive disease. If you look at the median of 50%, it drops down to 6 months. So this is the way time to progression is measured. Now, when you want to compare between two treatment outcomes, such as in this case, a placebo and a treatment group, then there's a difference between the two graphs you can see here. And this difference between the two event rates is called a hazard ratio. So I hope I've clarified how endpoints are measured in HCC, so that when we start talking about PFS, TTP, OS, ORR, you're aware of what we're talking about. Now, the other thing is mRECIST and RECIST. So what's the difference between the two? I think RECIST was basically developed for solid tumors. Now, they only measured RECIST by means of the size of the tumor. Now, we know that in HCC, size of the tumor may not be as important, because in the sorafenib studies, only 2 or 3% of those patients fulfill the RECIST criteria. But we know that the response rate was much better. And why is that so? Because of tumor arterial enhancement. So the size of the tumor may not reduce, but the tumor is dead because it's been fully treated by, let's say, TACE or by some other forms of therapy. So mRECIST is a modified criteria that takes into account intratumoral arterial enhancement in target lesions. Now here we have come to the definitions of PR, SD, and PD. So CR stands for complete response, where there's a disappearance of any tumoral arterial enhancement in all target lesions. PR is a partial response where at least a 30% increase in the sum of diameters of viable enhanced target lesions. Taking the reference, the baseline sum of the diameters of target lesions. SD stands for stable disease, any cases that do not qualify for either partial response or progressive disease. And PD stands for progressive disease, which means an increase of at least 20% in the sum of the diameters of viable target lesions, and the reference being the smallest sum of diameters of the viable lesions since treatment started. So here are the summary guidelines for EASL on HCC from this year. And we can see that on the vertical axis is the quality of the evidence. So there's high quality of evidence, there's moderate quality of evidence, and there's low quality of evidence. And the horizontal axis is the recommendation where there's a strong negative, there's a weak positive, and a strong positive. So you can see here on the left-hand side, there's very good evidence of adjuvant therapy after resection ablation, chemotherapy, other molecular targeted therapies, hormonal compounds, and yttrium-90. There's a high level of evidence that it doesn't work. So they have a negative recommendation. Then the evidence for external beam radiation, yttrium-90 for BCLC is moderate to low, and the recommendation here is weak. Similarly, nivolumab, downstaging to Milan criteria, LD, LDT, validated, extended to patients with downstaging to within Milan criteria, have got moderate levels of evidence, but it's a weak recommendation, probably because the efficacy of those treatments are not strong. And on the right-hand side, in the green traffic lights, are the high recommendations, and you can see here is graded by the level of evidence. So resection in non-cirrhotic liver, non-neoadjuvant therapy while on the waiting list qualifies as low levels of evidence. But the benefits may be quite good, so that's why the recommendation is strong. There's moderate levels of evidence for resection and microwave ablation. And the highest levels of evidence and strongest recommendations are for sorafenib, lenvatinib, regorafenib, cabozantinib, or ramucirumab. And this is second-line therapy. Sorafenib and lenvatinib is first-line therapy. Chemoembolization, radiofrequency ablation, percutaneous ethanol injection, and LT or LDTT according to Milan criteria. So that's the overall recommendations for HCC. Now, let's discuss molecular targeted therapies. All of you are very familiar with the different options available, and we know this is the pathways that have been explored in terms of molecular targeted therapy for HCC. But they've also found, and those pathways have been discovered because recurrent mutations were discovered in HCC, involving telomere stability, p53 cycle control with beta-catenin signaling, chromatin remodeling, the RAS-mTOR pathway, oxidative stress, JAK-STAT signaling, PDGFR signaling, and IGF signaling. All this have been found, but unfortunately, they weren't targetable when they were, when I say they're not targetable, therapies have been developed against them, but they were not effective. And I think this slide summarizes quite nicely the trials that have been completed in HCC. Now, I want to highlight in red here are therapies with negative results. So you can see here, there are many trials here that had negative results. Linifambanib, gefitinib, sunitinib, rifampicin, and so forth. And the ones in green are approved therapies because of their effectiveness. So we have seen here that systemic therapies, especially multi-kinase inhibitors have not really been very successful in therapy of HCC. And we've seen over the years that a lot of these drugs have failed because they were just not efficacious in clinical practice. Now, things have moved on, and you can see here that the tyrosine kinase or multi-kinase inhibitors have really been explored extremely thoroughly. Comparing placebo and sorafenib, this is a network meta-analysis where they compared all these different multi-kinase inhibitors against placebo and sorafenib. Now, some of them were not head-to-head comparisons, so you can do a head-to-head comparison using sorafenib or placebo as controls through a network meta-analysis. And you can see here, you can then compare all these different TKIs against each other. And this is nicely shown in the results of the network meta-analysis. And the way to look at this graph is what they call the Sukra score. The surface under the cumulative ranking curve is used to generate ranking information. I've highlighted here in pink the 3 top scores. You can see here that the best one is lenvatinib and also vantinib. Vantinib, both, and lenvatinib both score 0.77, has the highest score. And orantinib is also not doing too badly with a 0.68 score. So this tells us that not all multi-kinase inhibitors are actually failures. These 3 drugs actually are probably the best ones to use compared to sorafenib. And you can see here, sorafenib has a score of 0.35 only. And so these other drugs theoretically have twice the efficacy of sorafenib. So how should we choose molecular targeted therapy in advanced HCC? So this has been a slide I borrowed from Dr. Gee during the presentation of the Roche series. And she uses 4 strategies, looking at the patient criteria, the age, comorbidities, ECOG status, affordability, and tumor status, whether it's the symptoms, the response, the bleeding, extent of invasion, AFP in response to primary first-line therapy, the liver aspects, Child-Pugh score, etiology of cirrhosis, varices, viral hepatitis, and prior transplant. Of course, that may not be so easily available in the rest of Asia. And finally, the drug, whether it's first line or second line, availability and affordability. Now, if you fail the first line therapies, such as sorafenib, which has been used as first line, then you have the option of using second line. And the second line therapies here are listed: regorafenib, cabozantinib, and ramucirumab. Now, when we look at these, you can see that overall survival rate doesn't appear to be very different. Maybe the first 2 appear a little bit better than ramucirumab, but is that really true? So again, we do a network analysis of second line therapy, and these are the different options available. And when we look at the meta-analysis of this, we can see here, I would highlight the first 2 plots because these are the overall survival and the progression-free survival. And you can see here that only 2 drugs are doing better than everolimus, which is the standard reference, and that is regorafenib and cabozantinib. And when it comes to progression-free survival, you can add to that those 2, brivanib and ramucirumab. So we can see here that the therapeutic options for second-line therapy can be guided to us by the use of network meta-analysis. So when we are confused about saying, well, there's so many different options, what should we use? This is the way to make decisions about what to use for your patients who failed the first-line therapy. And this meta-analysis also tells us which particular subgroups will benefit. We can see here that for patients who have hepatitis B or C, there's no difference between the different drugs. But those who have macrovascular invasion, regorafenib and ramucirumab show a benefit compared to everolimus. And for those who have extrahepatic metastasis, regorafenib, again, is the only drug that shows an advantage. So this is how you would use data from the clinical trials in order for us to guide first-line therapy and second-line therapy. So let's move on to immunotherapy, which is the crux of the talk today. I'm afraid I'm running a little bit behind time. So really, cancer immunotherapy basically has been something that has been relatively new and now is picking up a huge amount of steam. So the principle behind that is that the tumor cells may be able to suppress the host immune system by various mechanisms. Number one, leading to excessive PD-1 stimulation so that it downregulates the T cell responses towards, or the immune responses towards the tumor. And secondly, by the generation of T regulatory or T suppressor cells. And there are probably more than one mechanism to this, but you can see here that there are a number of molecules that actually lead to T cell activation and the tumor uses to suppress it. So on the T cell side, there's B7-1, and its ligand is PD-L1. There's PD-1, and there's PD-L2. And then there's CTL4. And the ligand is B7-1 and B7-2. And you can see here the key drugs that have been tested. So for anti-PD-1, nivolumab and pembrolizumab are the two key drugs. For anti-PD-L1, azithromycin, durvalumab, and avelumab are the ones that are being tested. And anti-CTLA4 is ipilimumab and tremelimumab are the ones that are being tested. So the scientific rationale behind immune checkpoint inhibitors also includes anti-VEGF. It's become increasingly recognized that VEGF plays a very important role in enhancing immune checkpoint inhibitors. Excuse me. So anti-VEGF recognized by inhibiting suppression of dendritic cells maturation and enables efficient priming activation of T cells. Anti-VEGF also reprograms the activity of MDSCs, Tregs, and TAM, and enables reprogramming of the tumor microenvironment. Anti-VEGF also recruits and normalizes the vasculature, resulting in an increased infiltration of T cells, and also has the ability to restore anti-cancer immunity through T cell mediated cancer killing. And of course, when we say all that, I think we have put a lot of hope in immune checkpoint inhibitors. But I think there are some very important learning points. Single agent checkpoint inhibitors do not improve the outcomes. So when we say immune checkpoint inhibitors, these two studies show us that on its own, nivolumab, pembrolizumab, in the Checkmate 459 study and the Keynote 240 study, they were both phase 3 studies. They showed no benefit or marginal benefit compared to the standard of care, which was placebo in the case of the keynote and sorafenib in the case of checkmate. So the single agent inhibitors really aren't effective on its own, and they need to be used in combination. And I think we found that story very similar with multi-kinase inhibitors. Sorafenib did have an advantage as its own, but it really needed a partner. Now, this is the key study that was published in New England Journal of Medicine earlier this year, the IMBRAVE 150. And basically, it looked at patients with locally advanced or metastatic or unresectable HCC and had no prior systemic therapy. In other words, this was first-line therapy. And they were stratified by these 4 factors, by the region, ECOG status, by the presence of macrovascular invasion or extrahepatic spread, and baseline alpha-fetoprotein. And patients were randomized 2-to-1 to either receiving sorafenib or azithromycin and bevacizumab. And you can see that they continued treatment until loss of clinical benefit or unacceptable toxicity. Therapy was given every 3 weeks. And the primary endpoint was overall survival, as we said, and IRF-assessed PFS per RECIST 1.1. Now, overall survival, when we looked at that, we can see here that the overall survival rate was significantly higher in the azito-bev group, 85% compared to 72%. And in the Chinese subpopulation, which of course is not as pertinent to you, you also saw a similar efficacy, in fact slightly better, 87% compared to 64%. When we look at progression-free survival, again, 55% compared to 35%. And in the Chinese subpopulation, it's 48% compared to 31%. So I think we can conclude that this was a very good study showing that the overall survival and progression-free survival both were statistically significantly better than the control, which was sorafenib. Now, that is only the start of the story. You can see here that there are quite a few other studies now in progress looking at different combinations of checkpoint inhibitors, either in combination, durvalumab and tremelimumab, anti-PD-L1 and an anti-CTLA-4 combination. And we can see here that the overall response rate is 25%. And pembrolizumab and lenvatinib, which is an anti-PD-1 with a multi-kinase inhibitor. And that overall response rate is 42%. So it does appear, just from a very preliminary studies, that dual checkpoint inhibitors may not be as efficient as a combination of multi-kinase inhibitor or VEGF inhibitor and PD-1. You can see here that azito and bev clearly with an overall objective response rate of 65% really topped the two groups. So I think the design of these clinical studies gives us some clue about what strategies we're going to use in the future. Now, I'm sorry for this very busy slide because this summarizes the clinical trials of both the mono and combination immune therapies in advanced HCC. And I just want to illustrate here on the left-hand column here, the types of drugs that are being tested, right? For instance, there's the anti-CTLA-4, tremelimumab, anti-PD-1, sorry, pembrolizumab and nivolumab, and semisplumab. There's a PD-L1, durvalumab. Then there's the combinations, anti-PD-1 plus anti-CTLA-4, nivolumab and ipilimumab, durvalumab and tremelimumab. Then there's the angiogenesis and checkpoint inhibitors, and you can see there's quite a few of them being tested. Azito-bev has already been discussed, as I told you, but there's also more coming down the road. Pembrolizumab and lenvatinib, camrelizumab and apatinib, avelumab and axitinib. So this tells us that there's going to be more studies. And when we look at the objective response rate here, and we will look at azito-bev as a comparison, 37%. You can see that pembro and lenvatinib has a 45%, and cam and apatinib has got a 50%. So I think this is the beginning of exploring new combinations that are likely to improve the efficacy against HCC even more. So it's a very exciting time to be working in this field. Now, not only are we looking at combinations of immunotherapy and immunotherapy and multi-kinase inhibitors, but also immunotherapy and local regional therapy. Here you can see there's a combination of CTLA-4 and TACE and RFA. There's a combination of PD-L1, VEGF plus TACE, PD-L1, CTLA-4 and local regional therapy, PD-1 and local regional therapy, PD-1, MKI and local regional therapy, and so forth. So I think no stone is going unturned in terms of what possibilities can be explored, and what we should be doing in the future, I think remains to be discovered. Now, what about responders to immunotherapy and PD-1 therapy? I thought this was a very interesting study because this study looked at responders and non-responders, and they looked at the gut microbiota, and they found that there was a change in the microbiota, and certain certain gut phyla were more dominant in those who had a response to PD-1 therapy than non-responders. In fact, there was a more diverse species in the responders compared to the non-responders. So this is just by the way. But when you're looking at blood markers like blood levels of PD-1 or PD-L1, it didn't seem to correlate with response. So we can't use those to select patients for response. Now, coming to safety, of course, we know that giving all these drugs clearly has got risk. And when we look at the safety issues in the azito-bev IMbrave 150 studies, you can see here in blue the adverse events that occurred in more than 10% frequency and greater than 5% difference between the arms. You can see here that in blue are the azito-bev adverse events, and in orange here are the sorafenib adverse events. You can clearly see that sorafenib has far more adverse events than azito-bev, but azito-bev is not free of side effects. The main ones we should be concerned about, hypertension is a particular feature, grade 3 and 4 AEs in azito-bev, diarrhea, decreased appetite, abdominal pain, pyrexia, proteinuria, increase in ALT, and infusion reaction. And I don't need to go through the sorafenib ones with you because I'm sure you're very familiar with those. Now, when you're giving immunotherapy, you have to understand you may get immune-related adverse events, and these are the ones that are listed here, which is a result of excessive or increased immune activity, which is not surprising because you're basically stimulating the immune system by downgrading PD-1 or PD-L1. So the main organs involved are GI, liver, skin, neurologic, endocrine, and occasionally ocular manifestations. Factors that may predispose towards hepatotoxicity in those receiving checkpoint inhibitors include the class of the checkpoint inhibitor. CTLA-4 inhibitors have more incidence of immune-related adverse events than PD-1 and PD-L1. Underlying chronic liver disease is thought to be upregulated in chronic viral hepatitis, And we're not sure what impact this might have on those underlying chronic viral hepatitis. Dose dependency, the dose ranging study of ipilimumab showed that there were no grade 3 to 4 AEs at the dose of 0.3, whereas these toxicities increased to 30% when the dose had increased to 10 milligrams per kilo. I mean, that's not surprising because clearly, there is a dose-related effect. And HLA risk alleles might have been associated with some autoimmune-related immune reactions. Now, the other thing that we should be worried about, or we should be aware of rather, is that the timing of these adverse events are different for different immune checkpoint inhibitors. I think for the skin ones, they tend to occur initially, and they peak at around 10 to 20 weeks, while the GI ones tend to occur before the 10th week. You can see here, there's a small spike in it. While the less common AEs, such as the endocrine, they take long to occur and they peak over about 6 months, while the hepatic tend to occur around the 10th week mark, pulmonary start around that time, and the renal ones occur before the 20th week. On the other hand, ipilimumab, which is a CTLA-4 inhibitor, has a different profile. You can see here, rash and pruritus occur very early. They occur starting at the 4th week. Liver toxicity tends to happen after the 6th week, and diarrhea occurs before the 6th week. So I think you can see here that the pattern of the beginning of these side effects are different from drug to drug. So these are some of the common AE combinations. These are some of the common AEs, immune-related AEs with different immunotherapy combinations. Nivolumab, for instance, 22% had grade 4 and grade 3 adverse events, and the most common ones were pruritus and AST increase. Azito-Bev had 36% grade 3 or grade 4, and the most common ones were hypertension, pyrexia, ALT increase, proteinuria, pruritus. Brenzolimab and lenvatinib, 67% grade 3 or grade 4, and the most common AEs, more than 20%, are listed here: hypertension, AST increase, diarrhea, fatigue, hypothyroidism, palmarothema, dysphonia, proteinuria, and decreased appetite. Nivolumab and ipilimumab, 53% grade 3 or grade 4, and the most common ones are pruritus, rash, adrenal insufficiency, diarrhea, AST, ALT increase, hypothyroidism, and nivolumab and tremelimumab had 82% grade 3 and grade 4, and the most common ones were pruritus, rash, ALT, and AST increase. So you can see here the spectrum of AEs is different from drug to drug, and you just need to be familiar with the ones that are common in each of those classes. So the key principle is, first of all, you need to educate your patients. You need to monitor them. Most of these immune-related AEs occur during treatment, and definitely you can occur even after the last dose, so you need to monitor them after the complete treatment. So early identification is where the patients need to report a development of new symptoms or a worsening symptoms. Then intervene, evaluate, and consider other causes, because not all of it is due to immune-related events. They may have co-infection, or they might have picked up some sort of infection somewhere, and you need to be aware of that. So you need to individualize your follow-up and counseling and give high-dose systemic corticosteroids for severe events. So for grade 1 adverse events, treat symptomatic, continue therapy. For grade 2, you need to use moderate dose steroids, withhold doses until specific symptoms improve. There's a specific dose of the immune therapy. And grade 3 and 4, you need to use high-dose corticosteroids depending on the organ system. Grade 3 is to withhold the dose or stop treatment depending on the organ system. Grade 4 is to permanently discontinue the treatment depending on the organ system. So here is the outline of the systemic therapy for 2020. The first line treatment, you can see now, Azito-Bev, it gives you 22 months overall survival. Nivolumab, 16 months, while sorafenib and lenvatinib are around the 12 months. So first line therapy is listed here, and you can see the survival benefits of each of those classes of drugs. For second line, Ipi and Nivo are a good choice, and they give also a very good overall survival of about 20 months. But the other drugs, pembrolizumab, nivolumab, regorafenib, cabozantinib, give poorer survival rates around 12 to 10 months, and ramucirumab gives even worse than that, only about 8 months. But I mean, this is really going to change in the future, because really you can see that the landscape here is a very exciting one. There are many different combination options in unresectable HCC. You can combine immune regimens with anti-VEGF or a TKI, and you can see here there's a long list of different trials that are underway now, and this will really tell us the direction we need to go and what we should be exploring, what will work, what doesn't work. Cancer chemotherapy, immunotherapy combination with 2 checkpoint inhibitors are also being tested. I've already shown you some preliminary data on that, but there's more to come. So I just want to finish by concluding that immunotherapies through ICI is likely to have a large impact on HCC, and it already has. And this is due to its ability to produce durable and clinically relevant responses with few side effects as single agents. And you can see here that the adverse event profile is far better than that of sorafenib, and is a much more tolerable combination, a much more tolerable treatment regimen. Even though there are 2 drugs being used, the tolerability is much superior than that of sorafenib. PD-1 inhibitors provide significant treatment benefit to a subset of patients that cannot be identified in advance. Unfortunately, we don't have at this stage good data to look at responders and non-responders. The dual blockade of CTLA-4 and PD-1 or PD-L1 results in high response rates and longer overall survival despite enhanced toxicity. So I think PD-L1 is a bit of a problem, because there are clearly more immune-related adverse events associated with that particular class of drugs. So these combinations carry the risk of significant toxicities in cirrhotic patients that demand specific workup for diagnosis and management. That's not surprising, because the ones that actually need the therapies the most are the ones with more advanced disease. So if you have a Child-Pugh C, basically your treatment options may be pretty limited, because these patients may not be able to tolerate that drug. And I would advise you at this stage that all the studies have been done in mainly Charles A and at most Charles B7 patients. So it's not really been tested in Charles C yet. So I wouldn't rush in to give immune therapy to those patients with very advanced disease. So really the area of combinations of immune therapies and NKI with other therapeutic options is only just being explored. The optimal therapy for advanced and intermediate HCC will definitely improve over time. So with that, I'd like to thank you for your attention, and that I'll be happy to take any questions, and just to remind you that we do have some further webinars coming up with very prominent speakers, and please log into Singapore Hepatology Conference to view these webinars in the forthcoming weeks. Thank you very much for your attention. And don't forget to fill in the appraisal form.
Thank you, Professor Seng Gee, for the very elegant talk. We have a number of questions, but for the sake of time, we'll take a few selective ones. So there are a few questions like, to your option, which one do you suggest as the first-line therapy for HCC? With so many options now, what is your preferred first line?
Well, I think, there's no question that Azito-Bev is the top one at this minute. It's been approved in many countries, maybe not yet in Bangladesh, but Azito-Bev is clearly the one that's going to be the standard of care moving forward. Now, I must advise you that because it's only been approved this year, Azito-Bev hasn't really appeared in most of the guidelines yet. But I think its superior efficacy compared to sorafenib is clearly going to make that a part of the guidelines. It's only a question of time.
And thank you. Then the other question is, can we use this immune therapy that we're discussing in case of lenvatinib failure?
Okay, so if you want to use the lenvatinib failure, you have to look at second-line therapy. And I've already shown you that second-line therapy options are still being explored. I think Nivo and Ipi are possible, second-line therapy. This is something that is evolving, and we'll have more clarity on that in the next few months.
And one last question, that is there any effect on the etiology? The underlying etiology, does it influence the outcome of treatment with immune therapy? C, B, fatty liver, is there any difference in outcome?
Well, I think the data is still ongoing, but it doesn't appear to be a specific criteria. I've shown you some data on the subgroups, and certainly for the second line and TKI, there's no difference in responses between them. So at this time, it doesn't appear that that's the case.
I am having a bit of a problem with my net connection, so I am not sure whether you can hear me.
Yes, I can hear you.
So we'll now, I think, go on to the panel of experts. I must first thank Professor Seng Gee. It was a very elegant discussion, and we did enrich from it. Now going to the panel of experts for their expert opinion. It is first my pleasure to request Professor Salimur Rahman, former University Grants Professor of Bangladesh and former Professor Department of Hepatology, Bangabandhu Sheikh Mujib Medical University, for his expert opinion, please. Professor Salimur Rahman, sir. Sir, can you hear me?
Yes, yes. Thank you very much, Professor Mamun, for inviting me to be a panelist in this very important lecture webinar. I also thanks Dr. Rahim for inviting me and all the members of the Alumni Association to arrange this nice and new topics in the webinar. And I must thank Professor Lim Seng Gee for giving his very much valuable time from Singapore, for which will also help us to know about the immunotherapy on hepatocellular carcinoma, because this is also a very new light for us. Previously, we all know that we used to give immunotherapy in other diseases, many other diseases, rheumatoid diseases, and also in many other carcinoma. But giving immunotherapy in hepatocellular carcinoma is, I think, is a new light, which he has very elaborately and very nicely given us. You know, all the hepatocellular carcinoma in my country comes to us in a very late stage, where curative therapy most of the time is not possible. So I think this immunotherapy alone or as an adjuvant with other drugs is a very good possibility to introduce in my country, because HCC is not very uncommon. rather more common than the other advanced countries in the world. So I think if we can reduce the price of this immunotherapy by introducing a generic products, then we can also start giving these drugs to the patient to prolong their life in a very serious disease. And I have seen Professor Lim Seng Gee has told us a very long list of side effects. So far, I believe these side effects should be monitored very closely when we give these drugs. And I also think that these side effects can be managed with medical therapy. And last of all, I also thank
Shwapnil, Professor Salimur has finished his talk.
Yes.
Thank you, sir. Now, may I request Major General Dr. Azizul Islam for his expert opinion. General Aziz, please.
Yes. Thank you very much for allowing me to participate in this webinar conference. My respected teacher, Professor Salimur Rahman, and my respected teacher from Japan, Professor Fazl Akbar, and my senior colleague, Professor Kamrujaman Chaudhary, who is considered to me as one of the pioneer and father of improvement of modern oncology in the country, and my dear younger brother, Professor Mamun al-Mahtab, who is another scientist in the field of hepatology, and today's speaker, Dr. Lim Seng Gee. I congratulate all of you, and particularly I convey my thanks and gratitude to Professor Lim for his very outstanding and very learned presentation on the immunotherapy of the hepatocellular carcinoma. Actually, immunotherapy is a time-demanding drugs which are coming. In our country, though we are not yet achieved the standard of achieving or the availing the drugs, particularly immunotherapy drugs, we have been using different TKIs. For example, sorafenib, lenvatinib, in the management of stage C or the stage 4 hepatocellular carcinoma. According to my experience, there are some patients of the hepatocellular carcinoma who responds very well with the TKI, like sorafenib and lenvatinib. But in some patients, the response is not that satisfactory. So in my knowledge, some of my patients with the advanced disease, they are who are getting sorafenib, their survival is quite good. And fortunately, I have some patients who are still surviving without any disease progression for 1 year, 2 years, and very miraculously, some patient 3 to 4 years. But most of the patient, they do not respond equally with the TKI, particularly sorafenib, because I do have very little experience of the lenvatinib, because lenvatinib is available in our country for about last 2 to 3 years. But sorafenib is available for about quite a long time, 4 or 5 years, or maybe longer than that. And regarding the immunotherapy, actually, again, we have a very little experience, but we have started in the combined military hospital with the atezolizumab. So only 1 or 2 patients have started. We have started the drug. We have to wait for some times, few months. After follow-up, we can see how is the prognosis and how is the response of the drug to the immunotherapy. But I hope the atezolizumab itself as a single drug, or with the addition of the bevacizumab, or in addition with the either of the other TKI like lenvatinib and the sorafenib, because these 4 drugs are now available in our country. Particularly, bevacizumab is available for a long time, and the atezolizumab is available for about a few years with the help of the Roche Pharmaceuticals. So we have started using. We have to wait for some time to see the outcome of this immunotherapy along with the other immunotherapy or the other drugs. And so it is very difficult for me to comment how is the success rate and how is the mortality of this drug in our country. But according to Professor Lim, first-line drug will be in future atezolizumab and the bevacizumab. And I think and I hope we will be able to use these drugs also, because there are some patients who can afford. Most of the patients cannot afford the drugs, but there are some patients who will be able to afford the drugs. So thank you very much for inviting me in this webinar session, and I have learned a lot. Thank you all members, including Dr. Rahim and all other panelists and particular speaker. Thank you very much. Thank you.
Thank you, sir. It is actually, we should thank you because you have always been very supportive and joined us whenever we have requested you. Now it is my pleasure to invite Dr. Sheikh Muhammad Fazle Akbar from Japan for his expert opinion, please.
Well, Lim, thank you for coming and seeing after a long time. And also thanks to all. So I just like to be confined. I'm not expressing my gratitude in that manner. And the second thing, just we heard the presentation, excellent presentation given by Lim. So I don't like to give any comment over there. So these are the all things going on, and we can just adjust according to the condition. What I like to say that may not be very much acceptable at the very first time, the various drugs, whether it is the PD-1 or CTLA-4 immune therapy drug or other types of drug, other line of blocking drugs, probably would not stand the test of time for a long time, because cancer is highly variable, and the drug which is told, for example, the blocker is used for any types of cancer. Well, just tell me in very short 3 major limitations. In the cancer, there is a problem in the immunity. So that is for why we are calling about the immune therapy. So for again a switch, the immunity will be transmitted. It should be specific. It should be sometimes a little innate, but ultimately it should be the adaptive. What is the problem with the adaptive immunity? The major problem is cancer antigen undergo. So the thing is this, you have to give the immunity in the mutant conditions. And for the last 15 or 20 years, I'm trying to induce the cancer immunity in situ, the place where the cancer. So what we did in case of the liver cancer, we just give some danger signal in the liver cancer by alcohol, and after 48 hours, we give the antigen present in the right cell to induce the immunity over there. So if we can do it, we did in very small number of patients because we did not get the ethical permission from the Japanese government so easily, and we find that it might be one source of thing. So what I like to say, the combination thing is this: the cancer microenvironment is very hostile for any kinds of immune therapy, whatever it might be. It might be PD, it might be other things. It is very hostile. The second thing, the cancer antigen is always undergoing mutation. Third thing, even we have adequate number of cancer-specific T cells, it is not possible that they can work there because there is a boundary. There is a cancer capsule and there is a microenvironment bed. So what we have to do, we have to overcome these three limitations. And we're working in animal models and very recently got a permission to work in the human model, especially the liver cancer, to induce the immunity in situ. And this immunity can be existed for some time. So I don't like to extend the thing. For the time being, the drugs which are available is okay, but we have to continue about the evidence-based things because the drugs is a generalized drugs. It is for any cancer actually. In fact, it is not for liver cancer, but the liver cancer, we have to find the hepatic microenvironment in the cancer. We have to find the role of the capsule in the cancer. We have to find the inhibitory cell, for example, MDSC and other type of cell and the regulatory T cell in the cancer, and how to induce immunity in the cancer area and at the initial stage. Because if it becomes very big, then possibly it will not be possible to induce such an immunity. So it is not possible to give the commentary in 4 or 5 minutes. But anyhow, I like to tell that we have to do the evidence-based experiments, studies in human and also in the animal, and ultimately we have to place those in the clinics so that we can use in 5 years' time some sorts of new and evolving therapy. That's all what I can say.
Thank you for your comments. And I agree with you that there's a very complex situation in the liver. However, the proof is in the clinical trials, not so much the liver microenvironment. So what works in the clinical trials is the truth. So we can speculate whatever we want about whether it's adaptive immunity, whether it's mutant peptides or mutant epitopes. That is definitely true. But if it works, that means those things are superseded by the effect of the drug. So I think, and we should learn that lesson from the molecular targeted therapies. The molecular targeted therapies, they were so exciting because people found so many wonderful targets, but none of them worked, generally speaking. And sorafenib was the first one that actually showed some efficacy, and the efficacy was not wonderful. A lot of toxicity. So what we learned from molecular targeted therapy is that the science can be wonderful, but doesn't work in the clinic. So, that's just a disappointment. So it's the same thing. We can study the liver microenvironment in great detail, discover all these possible mutations that might be relevant, but whether it works or not, we don't know. And only the patient can tell us.
Yes, I agree with you. It's a long way.
Dr. Shwapnil, please continue.
Yeah, sorry, I'm very sorry. I'm getting disconnected and reconnecting again. I have just come back. Anyway, so thank you very much. So it's now my pleasure to invite the last panel of experts today, Professor Kamruzaman, for his expert opinion, please. Professor Kamruzaman Chaudhary.
Thank you, Dr. Shwapnil, and also the BSMMU Hepatology Alumni Associations and the Hepatology Department of ADUH. Regarding these presentations, Dr. Lim Seng has really excellently briefed about the total scenario of the liver cancer management, especially. And it's true, like the lung cancer, where we have seen about a lot of mutations has been detected in last 50 years. research. And a lot of TKI has been very effectively working in lung cancer management. But in the case of liver cancer, there is not that much effective mutation has been found in liver cancer management. And if you see the near about 37 years data, only the chemotherapy like doxorubicin, after that the sorafenib came back in 2007, and after that even 10 years later the lenvatinib came, and it gives only about 1 or 2 months benefit over survivals. And lastly, the immunotherapy has revolutionized, I should say, because it has given a more than 17 months benefit in all cases, especially when using the immunotherapy like atezolizumab and also bevacizumab. And definitely it needs a lot of studies to see how the mutations or other factors that generate the progression of the disease in the case of liver cancer. So it is more studies. But till now, what Dr. Lim has shown, the immunotherapies along with anti-angiogenic factors like BIVA has been given a very good results till now. And we are really frustrated regarding the management of the hepatocellular carcinoma. For 40 years in the development, there is no effective drugs has been in present management schedule, actually, like other disease like breast or lungs and other things. So thanks to the hepatology departments, BSMMU, and also Professor Lim Seng has really shown the management in hepatocellular carcinoma, how the present treatment is ongoing. Thank you all.
Thank you very much, sir. So we have come to the conclusion of this session. It was a very effective session, no doubt. Before I conclude, I must thank the participants who have given their time to listen to us. We're extremely grateful to Professor Seng Gee for giving time, to the panelists to give us time from the busy schedule. This was a joint webinar organized by the Bangabandhu Sheikh Mujib Medical University Hepatology Alumni Association with Singapore Hepatitis Conference. It was televised live on Raj TV from the Facebook page of Singapore Hepatitis Conference, as well as from the Liver Care and Research Center, the Facebook page of Forum for the Study of the Liver Bangladesh. We are conducting such seminars regularly, and we will keep you apprised as we have the next program. So, thank you very much once again. Have a very good day.
Thank you very much for inviting me, and it's a delight and pleasure to join with you for this joint webinar. And please join the future webinar series on SAC website. Just log in every Monday around 7:30 for the next series of webinars. 7:30 Singapore time, that is, which will be earlier in Bangladesh, of course. Thank you very much once again, and it's a great pleasure to meet all of you online and to speak to all of your doctors in Bangladesh. Wishing you a good evening and all the best for the future.
Thank you.